Good day to all of you. I, Dr. Beroze, Mistry, consultant physician, will present a talk on gestational diabetes mellitus. Diabetes mellitus is a chronic, lifelong ailment. It is characterized by impaired metabolism of carbohydrate, fats, and protein. Why? Because there is a deficiency of insulin. What is insulin? Insulin is a hormone which is produced by the beta cells of the islets of Langerhans, which are special cells in the body, and it is from the pancreas, which is a very vital organ in the human body. The insulin is low, or its function is impaired, or even if its production is high, it does not work to the normal. The normal function is to remove the nutrients and nourishment from the glucose and to give vitality to the body. Therefore, you get diabetes mellitus in the form of type 1, which is usually genetics, and there is a lack of insulin, low production. Type 2, that there is peripheral resistance to the use of insulin, and therefore the glucose level goes up. The third function is the storage. The glucose is stored in the form of mainly glycogen in the liver, and as the insulin cannot do it, this function also is impaired. Therefore, we are coming back to our topic, and that is gestational diabetes. This diabetes presents in the mother who is pregnant, and this occurs at 20 and 24 weeks of gestation. Why? Because during this period, the placenta produces anti-insulin hormones, which are estrogens, progesterones, placental lactogen, and cortisol. Also, with the production of these hormones, the insulin level goes up and there is hyperglycemia. Although in a normal pregnancy, the insulin level goes about 30% to do the normal function. But when there is a failure, as we said, underproduction, peripheral resistance, and in the storage, you turn up as gestational diabetes. Now, in the gestational diabetes to the mother, there are other risk factors, or you can say comorbids. These are age over 25 years, Asians, there is a high incidence, a poor obstetric history, usually multiparous females who have delivered twins and triplets in the past, large babies more than 9 pounds in weight, family history of diabetes mellitus, polycystic ovarian syndromes in the female, high blood pressure, and also ischemic heart disease. They are more prone to gestational diabetes. What happens to the fetus or the baby? Delivery mainly can be stillborn if it is untreated, or it can be preterm. The babies are big babies, lazy babies, obese and fat babies. Also, that they can develop severe jaundice after delivery, or there can be birth asphyxia because there is a fault in the glucose metabolism, and therefore the oxygen from the placenta uh, and the uterus exchange is impaired, and therefore you can get severe birth asphyxia, respiratory distress, and even death of the baby. So these things, and to the mother, as we see that gestational diabetes mellitus should not be neglected, and it should be taken seriously by the obstetrician together with the physician, and the mother should be treated well. Now, as we see how you diagnose gestational diabetes after looking at the risk factors. Number one, they can be asymptomatic when they are coming in the antenatal checkups, or they can be symptomatic. The classical symptoms, as we know, of our diabetes mellitus is more thirst, appetite is high, and also that weight loss is there, fatigue is there, increased urination is there. They can also present with repeated skin and soft tissue infections, mainly fungal infections in the vagina as well as in the urinary tract. They usually present. So this can give a clue to check the blood sugars. After looking at the symptoms and signs in the mother, you confirm it. How do you confirm it? You confirm it, one is a random test to look into the glucose in the blood, and if it is at a higher level, then the doctor rechecks it and reconfirms it by the glucose tolerance or glucose challenge test or glucose series. Here the mother is offered about 50 to 75 grams of glucose drink, which is concentrated, and the blood sugar levels are monitored after 1 hour, 2 hours and 3 hours. At 1 hour, it should not go beyond 95. At fasting, it should not go beyond 95. At 1 hour, it should not go beyond 180. At 2 hours, it should not cross about 155, and at 3 hours, not more than 140. So it is 95, 180, 155 and 140. This is the average levels. That is the doctor who decides best. After looking at any two levels which are out of the range, they are labeled as gestational diabetics. Now you have confirmed it. It is the prime importance of the doctor to improve the sugars of the mother. How it is done? Firstly, it is by a change in the lifestyle, that is diet, exercises and medication. Now, how is it by diet? By diet, it is that the change in the diet from refined sugars to complex carbohydrates. In vegetables, reduce the intake of potatoes, sweet potatoes, beetroots and carrots. In fruits, offer them one day an apple, one day an orange, one day an grapefruit, but not the sweet fruits like mangoes, watermelon. Then you can get sweet melons, bananas, restrict them. Also, other products which are complex carbohydrates in the form of legumes, grains, cereals that can be used moderately. Rice can be used once or twice a week, looking at the level of the blood sugars. Lean meats, poultry are advisable for the patient. Milk and milk products are also good to offer the patient, but they should also be low in fats. The cinnamon tea is good. Mustard seeds are good. They help in the production of more insulin and better metabolism of carbohydrates. So these can be offered to the mother. The second step is exercise. Now, of course, heavy exercises are not advisable at this stage of pregnancy after 24, 26 weeks in the third trimester. So allow them light exercises, activity should be there, walking should be encouraged, prenatal yoga should be offered to them if it is possible. The third step is medication. Now in medication, you have got oral medication, mainly it is metformin or glucophage. Maximum dose you can go up to 2 grams. And it can be with diets, exercises and metformin, or it could be diet, exercise and insulin. The insulins are variable. You can use 3 to 4 times short-acting insulins according to a scale which the doctor places in front of the patient, and that can be done pre-meals. And a long-acting insulin can be used at bedtime to stabilize their fasting sugars. Or the other way, an intermediate insulin, which is 70-30 or 60-40 or 20-80, which can be used in twice a day or even sometimes twice a day. But usually there is a 12-hour difference. The third insulin, as we said, long-acting, cannot be used mainly, but only it is together with regular insulin or glucophage. The mother should all have a glucometer. They should learn how to see their blood sugars at home and then work accordingly. The results are usually beneficial. The outcome is a healthy pregnancy. What happens if it is not at labor? As we said, you can go up to preterm labor, stillborns, and if the fetus is delivered, they are large babies. They are hypoglycemic at times because there is a flux of insulin from the mother to the fetus which was unused, and therefore at birth the sugars fall down. Then mothers are offered cesarean sections. Post-delivery, after delivering large babies, they can develop postpartum hemorrhage. They can have lacerations and tears and fistulas at the anus and at the vaginal areas or in between them, which is also not good for the mother. Then, as we had talked all about the baby, and that has to be looked in. Once the delivery is over, the placenta is out, the sugars start falling, which is usually in gestational diabetes 24 to 48 hours, the sugars tries to come back to the normal, but not in all. Therefore, the blood sugars in the mother should be rechecked after 4 to 6 weeks post-delivery, then after 6 months, 1 year, 3 years. Some patients are normal, but in others, they are not. And they can remain diabetics or they can develop diabetics, which is unsafe for future pregnancies. So this is important. So the mother after delivery should try to bring her weight back to preterm, that is pre-delivery, within 6 months. Breastfeeding should be encouraged. Light exercises, diet should all be controlled, And if you have to offer them these and the sugar settle, it is fine, or then you should treat them as diabetics. Thank you.
Thank you, madam.
Thank you.
Thank you.
Madam, usually it is said that gestational diabetes is not covered by, not controlled by oral hypoglycemics, but you are to give insulins. How's it?
No. Usually, if you ask me in my practice and with others, the obstetrician, before taking the physician on board, they try to give glucophage. Okay? They try. And if that works, it is fine. If it doesn't, then of course insulin. A better this thing is diet, exercise and insulin. I agree. But in some cases, what happens is that, as we said, the risk factors, obesity, they may be pre-diabetics, and in these states, glucophage works very well. And after 24 weeks of gestation, in these gestational diabetics, their sugars start coming down. And sometimes when you have put them on a high dose of insulin at 24, 26 weeks, their sugars drop down and they can get severe hypoglycemia. So in many cases, as glucophage is safe, one can use and not go straight away for insulin. But in certain, if they have a bad history and all, okay, fine, just remove glucophage and just be on insulin. Sometimes the dose of insulin is less when you add glucophage. That is also seen. So this is one thing.
Madam, एक misconcept कहें कि people are reluctant to use insulin.
Correct.
Throughout
Yes,
we are talking,
yes,
not
yes.
only in the gestational diabetes. So, what you would say for them?
In this is that you have to first build their confidence. This is very important, and this we see कि भाई मुझे सुई नहीं लगानी है ये वो. So that is true. They do it because they feel that this can cause more problems for them. How they are going to do, how they are going to store the insulin, and sometimes, you know, some have visual difficulties, and also they are alone, they are not confident to fill the insulin or use the pen or what. So you have to motivate them. The health educator is very important, and the health educator guides them, shows them. And also they should be told that, look, these are the complications which you will ensure if this is not done. And by oral medicines, they also have the side effects. You should tell them. So the doctor knows best, and therefore try to build their confidence and offer them insulin and train them and observe them. And then once they are in confidence, they will do it. And the cost is important. Sometimes they feel that no, they cannot buy the insulin and all. So all these factors are there. But if you try and say out of 100, you may be successful in many. So this is, I'm just giving a rough that it is true that they have a misconception, but not in all. Nowadays, if you bring that and the doctor, once they develop confidence with the doctor, they will listen to the doctor.
Madam, आपके ख्याल में gestational diabetes के बाद कितने लोग percentage wise keep as diabetics, continue as diabetics, और कुछ ठीक हो जाते हैं generally कुछ.
Percentage exact though I cannot say,
Roughly.
but roughly patients, you know, sometimes if they follow, we come to some conclusion. If they don't follow, they go elsewhere, or they come, say, after 2 years, 3 years, they are going to have another baby. Then we see that no, it was there. Some say that the baby sugar was there and we did not take care of and all. So in those cases, The percentage in all is not high. It is not high, but it is there. I would put it in that way. It is there because some females openly say that I had it, and after that, after some months or whatever, I went and found that my sugar was high. But they didn't follow after 6 months, 1 year, 3 years or so. But they followed. That means that the sugar was high, and due to some way it was picked up. But it was actually a gestational diabetic, which has now developed frank diabetic. So percentage wise, exactly I cannot, but it is there.
Usually it is covered up, but some portion
it is there. Yes, they develop. They develop, especially those who have family history and obesity and all. They do develop.
Eating habits.
Yes, they do develop.
मैडम आपने जिक्र किया कॉम्प्लिकेशंस में लेजी बेबी.
Yes.
Please बताएं ये क्या?
Lazy baby means that the baby, when you see the babies, normal babies, they're active, moving their limbs and all. This is a heavy baby, and mostly it is sleeping, and even the nurse turns the baby up and down. It doesn't show that activity. Later on, this inertia goes away slowly. They lose the way. But then in the beginning, if you can pick up that this is a diabetic baby. The pediatrician, without knowing the history, could say this is a large, it could be a diabetic baby. This is the thing. The laziness is that initially they are not that active as the young fetus who is delivered and moves the hand and all, cries slow, sluggish, all this. So they saturate. Everything is, of course, nowadays monitored, and the management is good. And even sometimes if they are delivered preterm, the saying is that we have everything artificial here, which is near to natural, that they have monitors, this, anything. So it can be, and they can go from 7 to 9 months in the incubators and all, and then back to normal. I've seen such babies, and after some months they are fine. They've come with their mother and all. So this is now modern obstetrics and peds. It's very advanced.
What would be your message for the pregnant ladies as well as for obstetricians, if you have something?
The main thing is that after delivery, before delivery, of course, they have to plan. They know some background of their own history. Then they should make the contact with their obstetrician, and the obstetrician does, just say in the first trimester it is monthly, in the second it is 2 weeks apart, the follow-ups, and in the last it is weekly or so. And if the obstetrician finds that the sugars are high, they cannot manage, initially they try, they have to involve the physician. The physician knows better in that, I believe. So that is very important. And if health education is there, that should be offered. So it should be a properly, you can say, manageable thing. And if it is done, the results are good. And you reduce the main thing is to bring the sugars to normal. Now in last 2 weeks or so, we had a lady, and she turned out to be a diabetic. About this, I think 24 this thing. So the obstetrician referred, and after reference, her sugars were 300 or so. And we started her on insulin straight away, and then with glucophage also. And in the second visit, weekly, the sugars and this was still high, but better. And in the third visit, last week, very good. So this is the thing, that if it is managed properly, results are favorable, the outcome is good.
Madam, usually gestational diabetes, babies born out of that during, is it necessary that baby has the effects, any bad effects?
Usually not. Some, of course, we have mentioned, but others whose sugars are well managed and They are fine.
Normal.
They are normal. Only thing, of course, their sugars should be checked and all that. But maybe the weight may be a little more, but otherwise they are fine. Because in the ultrasounds, which are serial ultrasounds, are done during pregnancy, the obstetrician picks up and tells that if it is, say, 28 weeks, the baby will be 30 plus minus 1 to 2 weeks. So this is already picked up on the ultrasound. You can pick it up. So that is the
Thank you, madam.